diabetes mellitus. Now we know that there are different types of diabetes mellitus, type 1, type 2, right? There is type 1.5. There's also talk about so-called type 5 diabetes mellitus, gestational diabetes mellitus, right? Now, do you mean to say that all the diseases have similar pathophysiology and the similar outcome? No. So diabetes mellitus is a group of metabolic disorders. They are not all same. They are heterogeneous disorders, but they share one common characteristic. So that's why I will define it as a group of metabolic disorders that share a common phenotype of hyperglycemia. They share a common phenotype of hyperglycemia. Hyperglycemia. So any condition where hyperglycemia is present, we can count it as diabetic. Of course, the underlying pathophysiology will be different. Okay. Now, the diagnosis of diabetes mellitus is what we will first talk about before we talk about the types. Now, for the diagnosis of diabetes mellitus, we will follow the American Diabetes Association or ADA guidelines. And right now, I'm going to mention the ADA guidelines 2025. Every year, American Diabetes Association updates its guidelines. And as a doctor, as a medical student, we are supposed to be updated with respect to diabetes, hypertension, ischemic heart disease, heart failure, and stroke. These are the most important diseases. They have burden on the society. Okay. Now, when do I say that a person is diabetic? I can call a person as diabetic if his fasting blood glucose level is above certain threshold, or if his 2-hour postprandial blood glucose level is above certain threshold, or if his HbA1c is above certain threshold. So what is that threshold? Now, normal fasting plasma glucose or normal blood glucose values range from 70 to 100 milligrams per deciliter. 70 to 100 milligrams per deciliter is our normal fasting plasma glucose. If this fasting plasma glucose level is more than or equal to 126 milligrams per deciliter, more than or equal to 126 milligrams per deciliter, we are going to call it as diabetes. Now, what about these readings between 100 to 126, like 101, 105, 110? These will be counted as pre-diabetes. So, if it is in the range of 101 to 125 milligrams per deciliter, we will call it as pre-diabetes, and we will give a specific name for this. Means this patient's fasting plasma glucose level is above normal but below the criteria for diabetes. So we'll call these patients as having what we call as impaired fasting glucose, impaired fasting glucose or IFG, impaired fasting glucose or IFG. Okay. Now this pre-diabetes has a tendency to progress towards diabetes. So that doesn't mean that if I have this blood glucose value, I'm absolutely safe. I'm slowly going to progress towards diabetes mellitus. If I'm using HbA1c as a criteria, what is a normal HbA1c? The normal HbA1c is supposed to be less than or equal to 5.6%. But if this is more than or equal to 6.5, more than or equal to 6.5%, the person can be called as having diabetes. And the values in between, that is 5.7 to 6.4. 5.7 to 6.4 will also be considered as the pre-diabetes. Will also be considered as pre-diabetes. Okay. Third one, let us say there was an individual whose fasting plasma glucose is in the normal range. HbA1c also appears to be not in the normal range, but after taking the meal, his sugars spike up. Can I diagnose the diabetes based on that? Yes, that can also be a criteria. So 2 hours after taking a meal, 2 hour postprandial glucose, the normal value is supposed to be less than 140 milligrams per deciliter. But if it is more than or equal to 200 milligrams per deciliter, we will call that individual as having diabetes. And the values in between, that is 141 to 199. That is like 140 to 199 milligrams per deciliter. I will count this as, this will be considered as pre-diabetes, and I have to give a specific name for this as well. I call this as IFG, impaired fasting glucose, if the fasting glucose values were in this range. And if the fasting glucose values, the postprandial glucose values fall in this range, we will call it as impaired glucose tolerance. Impaired glucose tolerance. Now I get a question from the students. Sir, if patient presents for a routine screening, I will get the fasting plasma glucose levels done. I will get the HbA1c done. I will get 2-hour postprandial glucose done. And that helps me to establish the diagnosis. But what if someone comes in emergency and I get one random blood glucose level checked and that value is high? Can I make the diagnosis of diabetes in that case when the random blood glucose level is high? Can we diagnose diabetes based on the random blood glucose levels? Izuki, you can go ahead. You can type the doubts in between the class. When I find the time, I will definitely address that. Can I diagnose diabetes based on the random blood glucose levels as well? Yes, we can diagnose diabetes even based on the random plasma glucose, which in India we call it as random blood sugar or RBS. Yes, we can diagnose diabetes even based on the random blood glucose level. So, but there is a criteria here. What is the criteria? If the random blood sugar is more than or equal to 200 milligrams per deciliter with symptoms of diabetes, then we can diagnose the patient as having diabetes. Now, what are the symptoms of diabetes? So please remember 3 P's of diabetes, that is polyuria, polyphagia, polydipsia, and now we have a 4th important symptom, that is weight loss. So if anyone presents with random blood glucose value more than or equal to 200 along with having polyuria, polyphagia, polydipsia or weight loss, we can diagnose the diabetes on the random values itself. But if I have to follow the ADA guidelines where patient is not having the symptoms of diabetes, then I cannot diagnose it based on the random blood glucose. I have to either go with fasting HbA1c or 2-hour postprandial glucose. Now comes another important question. What do you mean by fasting? The patient will say that, sir, I went home late in the night, so at 1 a.m. I had some meal, and at 6 a.m. I went to the lab and I gave my blood glucose level, and this is the result. So now can I diagnose the diabetes based on this value? Fasting also has to be objectively defined. Objectively, if symptoms are not present when the random glucose value is more than 200, we have to ask the patient to get these profile done: fasting plasma glucose or the fasting blood glucose FBS, PPBS, and HbA1c. Only then we can establish the diagnosis. But if symptomatic patient is there, then we can diagnose the diabetes based on the random blood glucose levels itself. Okay, clear? Okay. Now, what do I mean by fasting? So fasting here is clearly defined. Fasting refers to no calorie intake for at least 8 hours. No calorie intake for more than or equal to 8 hours. Means patient should not have taken any caloric food, means fats, proteins or carbohydrates, for at least 8 hours before giving the blood glucose value for FPG. Can the patient take water during this period? Absolutely yes. Patient can drink non-caloric fluid. Water he can comfortably take, but no carbs, proteins or fat during the 8-hour period. So does it mean that I can do the fasting plasma glucose only in the morning? No. If patient takes food and after that if he is not taking any calorie for 8 hours, even we can do the fasting plasma glucose levels during day also. So fasting is clearly defined as 8 hours of no calorie intake, whether it is day or night, doesn't matter. Of course, doing it for the night is more convenient, right? Now then, fasting is sorted. What about this postprandial glucose 2 hours after the meal we are going to check? Don't you think the carbohydrate content in the meal is going to influence the blood glucose level? Like if I get 2 patients and I ask one patient to go to get 2 patients, I ask them to get the postprandial glucose levels done. One patient goes and has some nice 1 box of sweets and some juices, Coke and all. The other patient goes and has some low glycemic index salads. And when I check their postprandial glucose values, do you think both of them will show similar readings? Of course not. The diet or what they are taking in the meal influences the glucose values. So that's why even this 2-hour postprandial glucose has to be standardized. So what do we do here? In gestational diabetes mellitus, you might have come across a term called as oral glucose tolerance test. So literally what we are doing here is nothing but oral glucose tolerance test. So what we do is 2-hour postprandial plasma glucose is defined as blood glucose taken 2 hours after patient consumes 75 grams of anhydrous glucose dissolved in water. Glucose dissolved in water. So the amount of carbs that is going into the patient's body and the form of carbohydrate is defined here. Patient has to take 75 grams of anhydrous glucose dissolved in water, take it, and 2 hours later we will check the plasma glucose levels. That is our postprandial glucose values, right? So let us summarize what we have learned so far. Diabetes is diagnosed when fasting plasma glucose value is more than or equal to 126 milligrams per deciliter. HbA1c is more than or equal to 6.5%, or 2-hour postprandial plasma glucose level is more than or equal to 200 milligrams per deciliter, or RBS more than or equal to 200 milligrams per deciliter in patients with symptoms of diabetes, that is polyuria, polyphagia, polydipsia, and weight loss. Okay. Now that we know how to diagnose diabetes or how to interpret the lab reports when someone comes to us with the blood sugar values, next thing is we also need to know the types of diabetes. But before we go into the types of diabetes, we will quickly revise the physiology. Because why so much of hullabaloo about the diabetes? Now, India is called as the diabetes capital of the world. And I think if you ask me, for me, if I develop diabetes, I will literally go into depression in comparison to me developing some infectious diseases. Because diabetes has plenty of long-term consequences. And that's why it's very important for us to understand why glucose must be tightly regulated, right? So please remember that as the blood glucose level goes increasing, if you follow all these patients with high blood glucose level for over the years, we start noticing that a lot of complications occur in them at higher frequency than someone with the relatively lower blood glucose values. I think all of you are aware of the complications of diabetes. We classify them as micro and macrovascular. So in the macrovascular, we have stroke, coronary artery disease, peripheral vascular disease. In microvascular, we have so many pathies: retinopathy, nephropathy, neuropathy. So I'm just taking an example of retinopathy. So there was a study, long-term study conducted in patients where they just looked at the relationship of the incidence of retinopathy and their fasting plasma glucose values. This graph, you get it in the Harrison also. So when I see this graph, when the fasting plasma glucose level was around 100, less than 5% of the patients had developed retinopathy over long term. Okay. As the values start increasing, right? So after 116 milligrams per deciliter, the incidence after 109 started increasing. After 116 milligrams per deciliter, it started strikingly increasing. So after certain threshold, the complications because of hyperglycemia go on increasing. So that is why our body has to tightly regulate the blood glucose value so that we don't face such consequences. But how will I regulate now? How the body will regulate this blood glucose level? Because our intake of sugars, carbohydrates, fats, and proteins is not going to be constant. It will be fluctuating. So sometimes the carb load is high, so after the meal, the blood glucose levels will significantly rise. Sometimes it is low, so they will rise a little bit. Now, how body will correct it? So as we know, we have two major hormones which are regulating the plasma glucose values. One of them is insulin and the other one is glucagon, right? They are antagonistic to each other. So how do they work? Now let us presume that there is someone who is in a fed state, means he has consumed food. Now food contains carbohydrates. So when he consumes food, there will be carbohydrate, and as the carbohydrate is absorbed, the blood glucose levels start increasing. And in response, the pancreatic beta cells produce insulin. Now what this insulin will do? This insulin will stimulate the glycogen synthesis or glycogenesis in the muscle. Muscle is one of the important storage organ for the glycogen. Similarly, it will also stimulate the adipocytes or the fat cells. What it will do to fat cells? At the adipocytes, it does stimulate the synthesis of fat from the glucose. We call it as de novo fat synthesis. Then third, liver is a very important metabolic organ, and what it will do to livers, in liver we will try to store this excess glucose in the form of glycogen. So insulin stimulates glycogenesis in the muscle and liver and adipogenesis in the fat. And as this whole process gets super saturated, we can also stimulate fat synthesis in the liver as well. So I convert this glucose to glycogen and fat and store it in the muscle, liver and adipose tissue so that my blood glucose level comes down. That's a basic mechanism of regulating the blood glucose level in the fed state. After meal, as the glucose level increases, I want to get it back to the normal range. So to do that, I stimulate the beta cells to secrete insulin. Insulin will stimulate the conversion of glucose to glycogen in muscle and liver and glucose to fat in the adipose tissue and to some extent in the liver. Okay. Now what if I am not taking sufficient calories and my blood glucose level, whatever it is all being used by tissues and blood glucose level starts tanking down. So in the starved state, instead of insulin, the pancreatic cells will produce glucagon, and glucagon kind of does the opposite of insulin. So what it will do, it will stimulate the adipocyte to release free fatty acids which can be converted to the glucose. It will stimulate the muscles to release the lactate amino acids which can also be converted to the glucose, and ultimately in the liver, so basically we are causing glycogenolysis, and in the liver we can also do gluconeogenesis from the glycerol amino acids. We can generate gluconeogenesis and we can release the glucose to circulation. Okay, now I have a question. How pancreatic beta cells get to know that the blood glucose level has got elevated above the threshold and I now need to secrete the insulin? Understanding this is crucial. Because as we go forward and talk about the management of diabetes, this pathophysiological understanding is going to come in handy. So I know that, okay, if blood glucose levels start rising, insulin will come, but how the beta cells get to know that blood glucose level is rising? Okay, so there's one important point to note. Do you think the insulin secretion only happens after I have taken a food, or there is constantly being secreted? So if I, like, see, to be very frank, I had to skip my dinner because I got stuck in the traffic and I was supposed to finish the class between 7 to 8 and then I would have had my dinner. Now I am not having dinner. So if I check my insulin levels right now, will it be undetectably low because I have not taken a meal? Or still my pancreas is going to continuously produce insulin? So if I take someone's blood glucose level for 24 hours, right, the insulin levels in his blood continuously for 24 hours, every half an hour or every 15 minutes, if I keep checking, I'll get a kind of graph where I get to know that as long as blood glucose level is more than 70 milligrams per deciliter, the beta cells keep producing insulin. Can anybody tell me why they keep producing insulin? As long as it is more than 70. So 70 is the threshold point for the beta cells to produce insulin. But why should they produce when it is, let us say, like my glucose level now may be 70 only. So why should my beta cells produce insulin? They should keep quiet, right? It's 70. It's like the lower limit of normal. Why should they produce? So whenever I ask students like what is the function of insulin, I get one answer. That is, sir, regulate the blood glucose level or decrease the blood glucose level. Which answer is right, but it's partially correct only, not perfectly correct. Why it is not perfectly correct? Its function is not only to maintain the blood glucose level in the normal range, but equally important is that insulin is required for the tissues to utilize the glucose. So if there is inadequate insulin, tissues cannot utilize the glucose. So entry of glucose from blood into the cells is facilitated by glucose transporters called GLUT. Particularly at tissue level, it is GLUT4. So expression of GLUT4 is under the influence of insulin. So if I don't have sufficient insulin, I cannot produce sufficient GLUT4, and if I cannot produce this glucose transporters from the blood, my cells cannot extract the glucose. So for my cells to be able to use the glucose, there should be some amount of insulin present in the blood. So as long as my blood glucose level is 70 milligrams or above, there will be constant production of insulin. So if I plot a graph of plasma insulin and type, there will be a constant production of insulin. This insulin, we will call it as basal insulin production. Basal insulin production. Means beta cells are continuously secreting insulin, little bit insulin, constantly, as long as blood glucose level is more than 70. Only when it goes below 70, they completely stop production of insulin. But after that, whenever I take a meal, blood glucose levels increase. So whenever I take a meal, blood glucose level increase and the insulin level spike up to get that blood glucose level normalized. If I take another meal, my insulin level will increase again. So every time there is a meal consumption, so there will be meal stimulated spikes. Meal stimulated spikes in the insulin levels. Constant insulin production. I take meal, blood glucose level increases. My beta cells will produce more insulin so that the blood glucose level can be brought down. Once the blood glucose level comes down, insulin level also comes down. If I take another meal, blood glucose level spikes up, proportionately insulin level spike up till the blood glucose level comes down. Once the blood glucose level comes down, insulin also comes down. Now, why am I stressing so much on this? Because tomorrow, if I have to manage somebody's diabetes with the help of insulin, and I want the management to be perfectly matching the physiology, then what I need to do? I need to give that person insulin which can mimic this basal insulin production so that there is constantly some amount of insulin present in the patient's blood. And after that, every time patient is going to take meal, to counter that, I need to give some special forms of insulin. And this is what we do. We have two kinds of insulins, long acting and short acting. So we give long acting so that patient has this basal level of insulin in the blood, which is required for tissues to utilize the glucose. And then whenever he's taking a meal, the blood glucose level is likely to spike up. So to counter that, we give a short acting insulin so that this insulin rises, reduces that meal induced blood glucose hyperglycemia. And then again, before the next meal, we will give another short acting. This is how we try to replicate the physiology when we try to treat the diabetes, right? So this is one graph I want you to remember. Constantly, there is some amount of insulin production. We call it as basal insulin production. This will function as long as blood glucose level is more than 70 milligrams per deciliter. And every time there is a meal, there will be a spike in the insulin. Now the question is how beta cells got to know. See, basal beta cells are tuned. As long as blood glucose level 70 plus, they will constantly keep producing. It's the routine. Having understood the basics of regulation of blood glucose level, we'll start with the classification of diabetes mellitus. All of us are familiar with type 1 and type 2. But the American Diabetes Association in all of its forms, including the ADA 2025, classifies the diabetes into 4 major categories. The type 1, type 2, gestational diabetes mellitus and other specific types. Okay. So we'll start with the type 1 first. Type 1 diabetes mellitus. What is the problem here? The two things to note here. One, diabetes mellitus or hyperglycemia results either because of insulin inaction or insulin deficiency. So the problem in type 1 is there is absolute insulin deficiency. Absolute insulin deficiency. What is the reason for this? That the reason for that is beta cell destruction, due to beta cell destruction. So beta cells are destroyed, and that's why your pancreas is not able to produce insulin. But rest of the mechanism, like insulin, if given, it will be able to create the glycogenesis as well as the adipogenesis, and it can decrease the blood glucose level. The rest of the mechanism is all fine, but production itself is reduced. That is type 1. Then we have type 2. In type 2, the insulin production is fine. Insulin production is not decreased. There is no insulin deficiency. Then what is the problem? Even when beta cells are producing sufficient insulin, this insulin is not able to work on its receptors. So the main mechanism here is there is insulin resistance. So in simple words, you can say that, sir, this is receptor defect. This is a pancreatic defect. This is receptor defect, where pancreas produce insulin, but it fails to work on the tissues because of abnormalities of the receptor or the second messenger systems. That is type 2. Gestational diabetes mellitus, I don't need to give you the introduction. Then what comes under this other specific forms? So there's a long list of diabetes that comes under this other specific forms. What I want you to remember here is the first one, monogenic forms. Monogenic forms. Okay, then second, diabetes due to pancreatic disease. Pancreatic disease. Then drug induced. The list goes on and on. I'm just reiterating the important ones. So can anybody name which drugs can cause diabetes? Drug induced diabetes or drug induced hyperglycemia? Hello everyone. Hello everyone. Okay, so please remember now. Can I pinpoint? Okay, let me reframe it in a different way. Is there any role of genetics when it comes to type 2 diabetes mellitus? Of course, yes, right? We know that diabetes runs in the family. Of course, there's a common saying that diabetes runs in the family because nobody runs in the family. But yeah, lifestyle is a factor, but genetics does contribute. Is there any role of genetics in type 1 diabetes mellitus? Yes, there is a role of genetics in type 1 diabetes mellitus as well. But can I pinpoint and say that this one particular mutation is responsible for type 1? No. Can I pinpoint and say that this one particular mutation is responsible for type 2? No. These are all multifactorial. Environment, genetics, again, multiple genetic factors all come together to give you type 1 or type 2 diabetes mellitus. But there are also some forms of diabetes mellitus where a single mutation is enough. If you have it, you will end up with diabetes. Such forms are called as monogenic forms of diabetes mellitus, right? Where we have single gene mutation. Single mutation is responsible for causing diabetes. There are two important examples I want to give you. First one is maturity onset diabetes in young. This had been the template for asking MCQs. How does it differ from type 1, type 2 and all? We will discuss that. The second one, example I am giving you is transient neonatal diabetes. Transient neonatal diabetes. MODY and transient neonatal diabetes. Then diabetes mellitus due to pancreatic disease, chronic pancreatitis, chronic fibrocalculous pancreatitis, right? Pancreatic cancers, they all can present with diabetes because beta cell is now getting destroyed because of the disease process. So insulin production can come down and we can have the diabetes. So that is coming under other specific forms. Drug wise, I think one of the common drugs that we all are familiar with is use of glucocorticoids. Then some immunosuppressant like cyclosporin, tacrolimus, they are also known to cause hyperglycemia. They can also induce diabetes. So these are other specific forms. Okay. Now we will study these individual types. We will learn how to diagnose them, what are the shared features and what are the differentiating features, and then we will talk about some rare forms. Okay. So first we'll start with type 1 diabetes mellitus. So in type 1 diabetes mellitus, there is absolute insulin deficiency. It means beta cells are not able to produce the sufficient amount of insulin. But what is the reason for this? The reason for this is beta cell destruction. Beta cell destruction. Now why the beta cells are getting destroyed? Beta cells can be destroyed mostly because of autoimmune process. Mostly, more than 95% of type 1 diabetes mellitus, there are antibodies and antibodies are causing the destruction of the beta cells. But in 5%, we don't find any antibodies, but there is clear evidence of beta cell destruction and insulin deficiency. So both those types where evidence of autoimmunity is there and where evidence of autoimmunity is not there will be called as type 1. As long as there is insulin deficiency because of beta cell destruction, it is type 1. So type 1 will be subclassified into two subtypes. We will call it as type 1A and 1B. We'll call it as type 1A and type 1B. So what is this 1A? 1A refers to autoimmune cause. So autoimmune destruction of pancreatic beta cells will be type 1A. and 1B is where antibodies are not detectable. So it will be considered as idiopathic. So type 1 is of either A or B type. A is autoimmune, B is idiopathic. Easy to remember. A for A. A is autoimmune, B is idiopathic. Okay. Now, why someone ends up developing this type 1 diabetes mellitus? Of course, it is an autoimmune disorder, and being an autoimmune disorder, there has to be certain risk factors, genetics and environmental factors. Okay. Now, when it comes to genetics, it's multifactorial. So, polymorphic variations of certain genes, polymorphisms in certain genes like CTLA4. Now, please remember this CTLA4 or whatever the polymorphisms I'm going to list. They're all important. If you're a final year student, you can vomit them out as the risk factors for various autoimmune disorders. So tomorrow they ask you for the vitiligo, what are the genetic factors which are increasing the risk? You can vomit the same names. If it is about alopecia areata, you can mention the same name. So you can use them at multiple places. CTLA4, then PTPN22, okay, and then interleukin 2 receptor. Okay. Apart from that, certain HLA haplotypes, mainly HLA DR3 and DR4. HLA DR3 and DR4. So if you're carrying DR3 and or DR4, you have higher risk of developing type 1 diabetes mellitus. Environmental factors also play a risk because many of us have those CTLA polymorphic variants or PTPN polymorphic variants which are considered as risk factors, but we won't end up developing type 1. Means genetics predisposes to the development of type 1 DM, but there has to be an environmental factor which triggers the autoimmunity, and then you have the antibodies which cause the beta cell destruction. So what are those environmental triggers? There comes viral infections. Okay, long list of viruses. You don't have to remember all those viruses, like it includes rubella, enteroviruses and all. Then very, very important and a concerning factor, that is vitamin D deficiency. Vitamin D deficiency is considered as a risk factor. One of the INICET MCQ was based on the next point that I'm going to tell you. Consumption of bovine milk proteins in the early life, that is your newborn period and the pediatric age group, increases your risk of developing type 1 diabetes mellitus. Means cow milk, bovine milk proteins, and lot of environmental toxins. These are all the environmental risk factors. Okay, so when these things come together, the genetics and the environmental risk factors, it triggers autoimmunity. Antibodies are produced. Those antibodies start causing the beta cell destruction. Now, before I go and talk about the antibodies, I have some question. If I get a patient with type 1 diabetes mellitus and I check his C-peptide levels, what will happen to the C-peptide levels? Will they be normal, elevated or low? What will happen to C-peptide levels? Are they going to be normal, elevated or low? What do you think? So please remember, why did I stress so much on the C-peptide levels? Because it can be a marker whether insulin production is normal, low or high. Very good, very good. So because here there is absolute insulin deficiency. So if I'm going to check the C-peptide levels, I'm going to expect the C-peptide levels to be low or undetectable. So in these patients, the C-peptide levels are going to be low or undetectable. The C-peptide is going to be low or undetectable because there is absolute insulin deficiency, low or undetectable. But what if I do it for a type 2 diabetes mellitus? So for a type 2 diabetes mellitus patient, C-peptide, at least in the initial stages, is going to be normal or maybe high. Why high? I'll discuss that later. Okay. Now, which antibodies are responsible for the development of type 1 diabetes mellitus? Most of these antibodies are going to target some protein in the beta cells, right? So what are those? The first antibody that we need to remember is anti-glutamic acid decarboxylase 65 antibodies, anti-GAD 65 antibodies. Okay. The second one is insulinoma associated antigen IA2A antibody. Okay. The third one is islet cell cytoplasmic antibody or ICA. Fourth one is called as a zinc transporter 8. So anti-ZNT8 antibodies. Anti-ZNT8 antibodies. The fifth one is insulin autoantibodies. Insulin autoantibodies. So here the antibodies against the glutamic acid decarboxylase enzyme. Here there is a specific antigen called as insulinoma associated antigen. So antibodies produced against that. Here various cytoplasmic proteins of the beta cells, antibodies are produced against that. Here the antibodies produced against a zinc transporter called as zinc transporter 8. And here the antibodies are produced against the insulin autoantibodies. Now, which one is the most important antibody among these? To be very frank, I cannot call any one of them as the most important. Why? Because the relative prevalence of these antibodies varies. Among them, the most common antibody seen in more than 70% of the patients with type 1 diabetes mellitus is going to be anti-GAD 65. But it is also seen in other conditions, including a lot of neurological disorders. So it is not most specific. If someone has anti-GAD 65 antibodies, doesn't mean that he is a patient of type 1 diabetes mellitus. He may not be. Okay. So then there comes an important MCQ point. Being the most common, it is the most sensitive antibody, right? This is the most sensitive antibody, but it is not very specific. So if they ask you what is the most specific antibody, the most specific antibody right now is insulinoma associated antigen 2 antibody. Most specific is IA2A antibody. This is the most specific antibody. So others, no specific MCQ point to remember, but whenever I have suspicion that it may be a type 1 diabetes mellitus, I have to do a battery of investigations. At least 2 or 3 of these antibodies should be tested. Routinely what we do is we go for anti-GAD 65, IA2A, and nowadays this anti-ZNT8. Out of them, if anyone turns out to be positive, then I can call it as type 1A diabetes. Okay. Now, what is this natural course of the disease when someone develops this type 1 diabetes? The disease progresses through stages because antibody, if like let us say I have this genetic preponderance, I have PTPN22 polymorphic variation that increases the risk of developing type 1 diabetes. And then let me say I got some viral infection, it triggered autoimmunity, my body started producing these antibodies that we just listed, right? So by tomorrow, will I be diabetic? No, because these antibodies are going to cause the beta cell destruction. So they will take some time. The moment one beta cell is dead, I'm not going to become diabetic. So as the beta cell destruction starts happening, the ability to produce insulin starts coming down, and only when a reasonable number of beta cells are dead, then I will manifest with diabetes. So it progresses through stages. So in stage 1, like let us understand it through a graph. In this graph, we will plot the beta cell mass on the y-axis, and on the x-axis, we will plot the time. So in the beginning, I will have very high amount of beta cell mass, right? High amount of beta cell mass. So that basically means I am right now normal. Beta cell mass is good, no antibodies, nothing, but I have genetic preponderance. So if I have genetic preponderance, some autoimmune trigger. Let us say at this point of time, I got one immune trigger. And once I have an immune trigger, body will start producing antibodies. And once the antibody production happens, they start destroying the beta cells and my beta cell mass starts coming down. But will I manifest with diabetes? No. Only when beta cell mass comes below a critical level, I will present with diabetes. As long as this beta cell mass is above this critical level, I will not manifest with diabetes. So at this point of time, will I have antibodies? Yes, because immune system has triggered and the antibody production has started. Beta cell destruction has started, but I still don't have diabetes. That will be called as stage 1. So in stage 1, antibodies will be positive, but no hyperglycemia. At this point of time, I may be positive for anti-GAD65 or anti-ZNT8 antibodies, but my blood glucose level will be normal because beta cell mass is still sufficient enough to maintain the blood glucose level. Okay, so this will be my stage 1. So in stage 1, I will have antibodies appearing, but blood glucose level will be normal. Okay, but as time progresses, my beta cell mass will further decrease because antibodies are going to cause the damage. So this stage, I'm going to call it as stage 2. Stage 2. This will be called as stage 2. So basically what is happening in stage 2? Further decrease in the beta cell mass, but still beta cell mass is sufficient enough to keep your blood glucose level in the range where I cannot call it as diabetes. So in stage 2 also antibodies will be there. Okay, but at this stage, if I take large amount of carbs, the meal induced spikes that happen, I may not be able to regulate that because for that I need to produce larger amount of insulin. I may not be able to maintain that. So in stage 2, there will be antibodies and I start developing something called as dysglycemia. Means sugars are not perfectly in the range where I can call it as diabetes, but meal induced hyperglycemias in the pre-diabetic range, it may start falling. So we'll call it as dysglycemia. It's not well regulated, but not sufficient enough to call it as diabetes. But as time progresses, the pancreatic beta cell mass further decreases, and once there is further decrease in the beta cell mass, right, then now I enter into stage 3. In stage 3, antibodies are positive and I have overt diabetes. So in stage 3, antibodies will be there and I will have overt diabetes. Now the blood glucose levels will be in the range where you can comfortably diagnose it as diabetes. Fasting may be more than or equal to 126, or post-prandial oral glucose tolerance test values will be more than or equal to 200, or HbA1c more than or equal to 6.5. I will reach in stage 3. So 2-3 MCQs have been asked. So which of the following is not seen in stage 1 type 1 diabetes mellitus? In stage 1, overt hyperglycemia is not seen, right? And then they have also asked in which stage of type 1 diabetes mellitus overt hyperglycemia is seen or patient can satisfy the criteria for diagnosis of diabetes. It is stage 3. Now, how rapidly one can progress from the stage 1 to stage 3 varies from individual to individuals. For some, it may be just weeks after the immune trigger. For some, it may be months. For some, it may be years. Okay, so this is the story of the type 1 diabetes mellitus. Overt means obvious hyperglycemia. Obvious hyperglycemia we have already defined when we call it as fasting more than or equal to 126 milligrams per deciliter, post-prandial more than or equal to 200 milligrams per deciliter, or HbA1c more than or equal to 6.5. Values less than this but still not normal, which we classically call it as pre-diabetes, that will be fitting into this dysglycemia. That is stage 2. Clear? Okay. Now, before we move forward, if I have to summarize the type 1 diabetes mellitus, key points we have to remember here is absolute insulin deficiency. Number 2, C-peptide levels will be low or undetectable. Okay. Number 3, autoimmunity is responsible for the majority of cases because more than 95% of patients will be autoimmune or type 1A diabetes mellitus. Now, looking at this whole pathophysiology, right, I want you to tell me a few more points. Can this patient be managed without insulin? Can this patient be managed without insulin? Dysglycemia means impaired glucose regulation, but not in the range, blood glucose levels are not in the range where I can call it as diabetes. Yes, these patients cannot be managed without insulin. Why? Two reasons. One, there is absolute insulin deficiency, right? Now you may create mechanisms for this patient to excrete more glucose, decrease glucose absorption, but I have already told you, insulin is essential for the cells to utilize glucose. So if there is no insulin, cells will not be able to utilize the glucose. So for my cells to use the glucose, I need some amount of insulin. So these patients need to be managed with insulin. So the key point that we learn by understanding the type 1 diabetes pathophysiology is that type 1 diabetes is characterized by few things. So the first point I want you to remember is that age of onset. I'm not saying that all patients this will be the age of onset, but it is usually less than 25 years of age. Usually less than 25 years of age. Second, the patient will have low or undetectable insulin or C-peptide levels. Third, these patients will have autoantibodies most likely. Generally, they will have autoantibodies positivity. And the fourth point, insulin dependence is there from the day one of the diagnosis or day one of developing the diabetes mellitus. Insulin dependency right from the beginning. And the fourth one, these patients, because they have absolute insulin deficiency, the cells will not be able to utilize the glucose. They switch into the ketogenesis. So they are generally prone for ketosis, or what you call as DKA. They are prone for diabetic ketoacidosis. Right? These are the key points that we need to remember about type 1 diabetes mellitus. Now from here we will go to type 2, and for type 2 we will study in comparison. Few points, if we can compare with type 1, we will be able to remember things better. So what is type 2? Type 2 is definitely more common than type 1. And the mechanism here, as we have already discussed, the main mechanism is insulin resistance. But as the disease progresses, there is also destruction of pancreatic beta cells. So that's the main mechanism. To some extent, the insulin secretory defects, insulin secretion defects may be involved. So can these patients develop insulin deficiency? Yes, later in the course of the illness. But in the beginning, insulin production is normal. It is the receptor defect where insulin is failing to act. Now, what are the risk factors for someone to develop this type 2 diabetes mellitus? So, of course, genetics plays an important role here as well. But when it comes to genetics, right, it is multifactorial. I cannot pinpoint one genetic abnormality. It is multifactorial. Okay. And then second, lifestyle, right? Lifestyle, we can call it as environmental factors as well. And it is more of environmental factors which have a major influence. And when it comes to environmental factors or the lifestyle factors, what are the important risk factors for someone to develop insulin resistance so that he ends with type 2 diabetes mellitus? Right. So that includes increased calorie consumption, so taking more sugar or more glucose or more carbs than required, right? Increased calorie intake, sedentary lifestyle, chronic stress, These are all important risk factor. And type 2 diabetes mellitus in the early stages, in the pre-diabetes stages, has a perfect chance of reversal. You can halt, slow down, or revert the progression of the pre-diabetes to diabetes if it is type 2. Type 1, yes, we are still investigating. We are trying to develop mechanisms to halt the antibody production. Even vaccines are being developed. But when it comes to type 2, it's still at in like experimental stages. As of now, if you are prone to develop type 1 and some immune trigger happens, you will mostly end up developing type 1. It's not largely preventable, but type 2 is highly preventable even before the onset of the disease, and even once the disease process has started. Pre-diabetes stage, it's perfectly reversible if the calorie intake, the glycemic load of the food is reduced, sedentary lifestyle is switched with active lifestyle, it is reversible. So these are the important factors. So that's why traditionally we say that diabetes runs in the family, because nobody runs in the family. And it also explains why right now in India, we find ourselves as the diabetes capital of the world, right? The number of patients with diabetes in India and China is humongous. The reason for that is in last 20, 30 years or maybe like 40 years, country has developed. The economy has boomed. So there is more financial growth with the country. And as money reaches people's hand, the access to calories, junk and all becomes easier. So when we were kids, all the things that are now eaten as junk were rarely available to us. Like once in 6 months or once in a year, our parents could give us as treat some junk. Now, what was a treat to us is part of the routine for today's kids. So as the calories become easy to buy, the incidence of type 2 diabetes starts going up in that population. And right now India finds in that place where money is not like very difficult to earn. So people have decent amount of money, and you can easily buy a pack of chip on a daily basis from any of the shop, and thus you take small steps towards diabetes on a daily basis. Okay. Now, before we go forward, we will understand how does this type 2 diabetes mellitus differs from type 1. So type 2 diabetes mellitus, as we just learned, the main mechanism is insulin resistance, right? Insulin resistance. So in the type 1, the age of onset was usually less than 25 years. Type 2 diabetes usually, because if I ate half a kg of laddu, tomorrow I will not have severe insulin resistance, and day after tomorrow I will not be diabetic. It's a very slow evolving process. In fact, studies after studies have shown that the adipose mass has direct correlation with insulin resistance. Like more the fat mass in the individual, more is the insulin resistance. So slowly we will start gaining weight, start building the fat mass, and then start developing the insulin resistance. So it's progressive. So age of onset. So when I was an MBBS student, our teachers used to say the age of onset of type 2 diabetes mellitus is after 40 years. Now we won't say 40, the bar is reduced. It's usually after 30 years. Age of onset is after 30 years. The type 1 was before 25 years of age. Okay. Second, if I do the C-peptide levels, it was undetectable or low in type 1. Now here, because there is no insulin production defect, there is no insulin deficiency. So if I do the C-peptide levels or insulin levels, they will either be normal or they can be high. Why will they be high? Because whenever there is resistance to the action of insulin, what beta cells should do? Blood glucose level is going high. Insulin is not able to work. So blood glucose level is going high. And as the blood glucose level starts going high, more and more glucose enters the beta cells, it will stimulate more insulin release, right? So in response to resistance, there will be more insulin production. So we can have hyperinsulinemia because of the resistance. And how many of you have seen these people with some black patch on the neck or some multiple skin tags, especially in diabetics? How many of you have seen this darkened neck? And what do we call it as? We call it as acanthosis nigricans, right? And then skin tags also is a sign of hyperinsulinemia. How is this a sign of hyperinsulinemia? Many of you may be familiar with this one mediator of growth hormone action called as insulin-like growth factor 1 or IGF-1. Why have we called it as IGF, insulin-like? So please remember, IGF-1 is not the only growth factor. Even insulin is a growth factor. So insulin stimulates the proliferation of cells. It may be doing that by making more glucose available to the cells so that cells can replicate more efficiently. So when there is high amount of insulin, the cells are hyperstimulated to proliferate, and that proliferation of keratinocytes gives rise to that acanthosis nigricans. So it's an indirect sign of insulin resistance. Skin tags can also be a sign of insulin resistance, right? So as the insulin level increases, we can have those acanthosis nigricans, and also it's a response to insulin resistance. Third, so in type 1, when we were talking about it, we said autoantibodies are present, insulin dependency is right from the beginning, and these are prone for decay. But when it comes to type 2, right, the autoantibodies will be negative, because here it is not the antibody mediated destruction of the pancreatic beta cells. They will be negative, but there will be presence of signs, or there may be presence of signs of insulin resistance. So what are the signs of insulin resistance? Mainly acanthosis nigricans, and presence of skin tags. Nigricans and presence of skin tags. Okay, then what about insulin dependency? Do I need to start the insulin right from the beginning? The answer is no. Here, the beta cells are not absolutely destroyed. They are capable of producing insulin. In fact, they are producing normal amount of insulin or more than normal amount of insulin to overcome the resistance. But because there is insulin already there in the blood, at least some amount of glucose will be entering the cells. So tissues are not craving for glucose. Tissues need may be met to some extent. So now I can try to manage this patient's blood glucose level by alternate means without going to the insulin. In type 1, there was absolute insulin deficiency. So at least to make the tissues utilize the glucose, I have to give them insulin. So here, insulin dependency is not absolute, right? So it comes at late stages. Insulin dependency comes at late stages, not in the beginning, right? Not in the beginning. Then what about being prone to ketosis? Theoretically speaking, type 2 diabetes mellitus is not supposed to be ketosis prone because there is some amount of insulin. So cells will still be following the glucose as the main metabolic fuel. They don't need to switch to the free fatty acids as the tool for the generation of ATPs. But in case of type 1, insulin is absolutely absent. So cells cannot use the glucose. They have to rely on free fatty acids for the cellular energy needs. So that's why they end up generating ketones. Theoretically speaking, here it should not be. But for some unknown reason, Indians are particularly prone to develop the ketosis even when having type 2 diabetes mellitus. So point to note, may or may not be ketosis prone. May not be ketosis prone. So this summarizes the type 2 diabetes mellitus and the key differences between type 1 and type 2. So in simple words, I would say type 1 is seen in relatively young pediatric or the young individuals. Type 2 is seen mainly in adults, right? Proper adults. Type 1, C-peptide level will be low or undetectable. Type 2, it will be normal or high. Antibodies will be positive in type 1. Antibodies will be negative in type 2, right? Type 1 will not have the signs of insulin resistance. Type 2 can have the signs of insulin resistance. Type 1, right on the day of diagnosis, I need to prescribe insulin to the patient. Type 2, if I can manage without insulin, good. Only when I reach a point where other drugs are not able to get the glucose under control, then I get to the insulin, right? This is type 2. Now in this classification that we were talking about, we learned about type 1 and type 2. These are the two major types. GDM will discuss later. Some specific forms among them, MODY, I need to discuss. But then there's also one more type, which is called as type 1.5 or LADA, latent autoimmune diabetes of adults or LADA. This is also called as type 1.5 diabetes. Why is it called as type 1.5? Because it shares the features of type 2 as well as type 1. So there are some common shared features. That's why it is placed between 2 and 1, somewhere in between. That's why it's called as 1.5 or LADA. Now, what are the features that it shares from the type 1? The features it shares from the type 1 is that it will be positive for the antibodies. Autoantibodies are positive in these patients. Okay. Then what it shares with the type 2? Usually the age of diagnosis of type 1 is less than 25 years. Now, most of these patients, age of onset is going to be more than 25 years, which is unlike the type 1, right? That is first feature. Second, in case of type 1, the insulin dependency is there right from the beginning. But here, there is, like in type 2, there is no insulin dependency from the beginning. Insulin independent, at least in the beginning. So it shares some features of type 2, some features of type 1. That's why it is called as type 1.5. Now, if you ask me, sir, then why didn't you mention that in this classification, or why this American Diabetes Association did not mention this 1.5 in between 1 and 2? And why are you talking about it as a subtype? So please remember, for me, type 1 and type 1.5 are no different. Basically, what I count is type 1.5 is a mild type 1. So where antibody production is low, and that's why the beta cell destruction is also slow. So usually what happens is, if it is type 1, once an immune trigger happens, I will go through the stage 1, 2, 3, and I will end up at a value where antibodies have destroyed the beta cell mass significantly, and I will present with diabetes. Right? Usually this happens before 25 years of age. But if the antibody load is low, then there will be slow decline in the beta cell mass. So the graph is going to go somewhat like this, right? Slow destruction of the beta cell mass, and I will reach a point where I can be diagnosed as diabetes after 25 years of age. So basically a slow progressing type 1 as you think of, right? So in such cases, if I diagnose these patients, right, way before they're completely insulin deficient, like this is a point where if I catch them, the beta cell mass is still reasonably good. So I will have some amount of insulin production. That is why at least for initial few months, I may not require insulin. My sugars may be managed without insulin. So in very simple words, what is this type 1.5? It's a slow progressive type 1. Because it is slowly progressing, the beta cell mass is slowly decreasing. So you catch hold of these patients much later, after 25 years of age. And when you're catching hold of these patients, insulin deficiency is there, but it is not absolute. Still some amount of beta cell mass is there, some amount of insulin production is there. So because of that, at least initially, maybe for 6 months, 1 year, 2 years, you may be able to manage them without giving insulin, because beta cells are still producing some amount of insulin. But later, after 6 months, 1 year, 2 years, the remaining beta cell mass will also be destroyed by antibodies, and then they will become insulin dependent. That is the summary of the latent autoimmune diabetes of adults. So if I have to graphically represent what are the shared features of type 1, type 2 and LADA, in all the three, blood glucose levels will be high. There will be hyperglycemia. But in case of the type 2, antibodies will be negative, C-peptide will be normal or high, and insulin deficiency will be a late manifestation. In case of type 1, antibodies will be positive, C-peptide level will be low or undetectable, and insulin dependence is from the beginning itself. In LADA, antibodies will be positive. So it is sharing that with the type 1. C-peptide levels, because I am detecting it at a stage where some amount of beta cell mass is still there, C-peptide levels may be normal or low, but not undetectable. But in case of type 1, it is usually undetectable, right? It's critically low. Insulin dependency, in type 1, it is from the beginning. In type 2, it is late. In the LADA, it is at least not in the beginning. Not in the beginning. So one thing that is shared by all the three is hyperglycemia. And then the shared feature between LADA and type 2 is that there is no insulin dependency in the beginning and age of onset is adults. And shared between LADA and type 1, antibodies, right? That's why it is called as latent autoimmune diabetes of adults, means age of presentation is in the adulthood after 25 years. And autoimmune because antibodies are there. And it is called latent because it is slowly progressive, right? For years together, it is progressing. And by the time he becomes an adult, 30 or 35-year-old, then the disease manifests, right? That's why it is called as LADA or latent autoimmune diabetes of adults or 1.5. So there's a well-laid ADA criteria for the diagnosis of this. The first thing is that the age of onset should be more than 25 years. Okay. Presence of islet antibodies, at least one antibody should be positive that we have listed for type 1 diabetes mellitus, and there should be no insulin requirement for at least 6 months after the diagnosis. At least 6 months after the diagnosis. Then we call it as LADA. So basically antibody positive diabetes presenting after 25 years and initially not requiring insulin is LADA. Antibody positive diabetes presenting before 25 years and requiring insulin on the day of diagnosis itself is type 1 diabetes mellitus. Okay. Now comes this specific form that we had discussed. Apart from type 1, type 2 and in between the 1.5, the monogenic forms, one of them is MODY, maturity onset diabetes in young, right? Again, in medicine, no, the beauty of medicine is that a lot of information is embedded in the name. Like for this, we call it as latent autoimmune diabetes of adults. So by the time I say autoimmune, you know antibodies are present. I say adult means age of onset is late, not like the type 1 diabetes mellitus. And latent means it is slowly progressing, right? Similarly, the name of this specific form of diabetes is maturity onset diabetes in young. Maturity onset means onset is after the maturity, means not in the pediatric age group for sure. Okay. Then this is a monogenic form of diabetes. It's a monogenic form of diabetes. Type 1 and type 2 are multifactorial, genetics, environmental factors and all come together. This is a monogenic form of diabetes mellitus. What does that mean? It is due to single gene defect. Due to single gene defect. So one gene defect is enough to cause this form of diabetes. Okay. Now, what this gene defect will do to the patient? Blood glucose level rises, beta cells recognize it and then produce insulin, blood glucose level gets normalized. That is the physiology. In type 1, what happened? Blood glucose level rises after the meals, but beta cells, even if they're able to recognize, they're not able to produce insulin because the number of beta cells is depleted. In type 2, blood glucose level rises, beta cells recognize it, number of beta cells is normal, so they produce normal amount of insulin, but this insulin fails to work on the receptors, right? There is resistance to this insulin's action. That is type 2. Type 1.5 or LADA is nothing but a slowly progressing type 1 diabetes mellitus. Now, what is the defect in these patients? So in these patients, the main defect is that blood glucose level rises, beta cell number is normal. If beta cells produce insulin, insulin will be able to work on the receptors. The receptors are also fine, but there is abnormality in either sensing the glucose or releasing the insulin, like this pathway that we discussed here. In the response to rising glucose, either recognizing the glucose, there is a defect. Rising glucose, the beta cell is not able to recognize it. So if it does not recognize that, okay, that is an enemy who is coming into my territory, I will not send my army. So recognition is important. So either beta cells are not able to recognize the rising glucose, right? Or even if they recognize, they're not able to secrete the insulin. For secretion, there are a lot of steps involved. So defects here, secretion can be impaired, or the beta cell development itself may be abnormal. So here, beta cell mass is not depleted. Insulin's action is fine, but sensing the glucose or releasing the insulin is the main problem. Just to give you an example, like when you see this pathway, glucose conversion to ATP includes a very important rate limiting step catalyzed by the glucokinase. So if there is a mutation in this glucokinase in the beta cells, then I may not be able to convert this glucose to ATPs. So even when large amount of glucose enters the cell will not be able to cause this depolarization of the membrane, calcium influx and release of the insulin. So here beta cell number is fine. Insulin, if released, it is able to work, but somehow sensing and release, this process is getting disturbed. So in the MODY, because of these gene mutations, there is impaired insulin secretion or impaired glucose sensing. So in these patients, there is impaired glucose sensing or insulin secretion. Sensing or insulin secretion. There is no insulin resistance. So there is no insulin resistance. There are no autoantibodies. There is no antibody mediated destruction of the pancreatic beta cell. Okay. Now, being a single gene defect, there can be a mode of inheritance, right? Because we're talking about single gene. So now we can also talk about whether it is autosomal dominant, recessive, or X-linked inheritance. All the forms of MODY that we know, MODY is not one disease, it's a group. All the forms of MODY we know, they are autosomal dominantly inherited. They are autosomal dominantly inherited. So the mode of inheritance is autosomal dominant. So that's why we're going to call it as monogenic form. A single gene mutation inherited autosomal dominantly. So now can you tell me, for the diagnosis of MODY, do I need to have the family history or no? Like, can I diagnose the MODY? Can I diagnose the MODY without any other family member, the like father or grandfather being affected with MODY? Can I diagnose MODY? No, there is need for the family history because it is autosomal dominantly inherited. If it is autosomal dominantly inherited with good penetration, then there has to be, like, if I am having MODY being autosomal dominantly inherited, one of my parents should also have MODY, right? So that's why for the diagnosis of MODY, there is a need for family history. Okay. Now there are different types of MODY, and related to MODY, multiple MCQs have been asked. As of now, we have recognized 14 types of maturity onset diabetes in young. Out of them, 6 are relatively more common. Majority of the MCQs are going to come from these 6. Okay. So what we will do is we'll put a table, types of MODY, which is a gene defect, and some extra MCQ points that we need to know. Okay. So type 1, 3 and 5, they are due to mutations in hepatocyte nuclear factor. Why am I writing about 1, 3 and 5? Because I want to make it easier for you to remember. Odd numbers I'm picking up. 1, 3 and 5 are odd numbers. Odd number MODYs are due to HNF mutations. So HNF4 alpha mutation results in type 1 MODY. HNF1 alpha mutation results in type 3 MODY. And HNF1 alpha mutation results in type 3 MODY, and HNF1 beta mutation results in type 5 MODY. Okay. Then MODY in mutation in glucokinase gene. We were just talking about it, right? As the glucose enters the pancreatic beta cell, we will activate a process of generating ATPs using this glucose, and one of the first step is phosphorylation with the help of glucokinase. If there is a mutation, even when more glucose enters the cell, we will not generate ATPs. If I'm not generating ATPs, I will not cause potassium efflux and depolarization of the beta cell membrane. Calcium will not come in. So cyclic AMP will not get activated. I will not secrete the insulin. Beta cell is normal. insulin is normal. If insulin produced, it will be able to work, but despite rising glucose, I will not be able to secrete the insulin, right? Okay. Then mutation in insulin promoting factor or insulin promoter factor, IPF1, promoter factor 1 or IPF1 mutation results in type 4 MODY. And then there is one more factor called as neuronal development factor or neuro D1 mutation results in type 6. Okay, all of them are autosomal dominantly inherited. The key point to note here is that among them, they ask what is the most common MODY. The most common MODY is type 3. Type 3 is the most common maturity onset diabetes in young, accounting for more than 50% of all cases, more than 50% of all cases. And then MODY 2 is the second most common MODY, accounting for more than 1/3 of cases. When I say more than 1/3 cases, almost 33. So 50, 33, almost 80, 90% of MODY cases are belonging to MODY 2 and MODY 3. The other MODYs are relatively less common, right? This MODY 1 is uncommon, seen in less than 5% of cases. And the other forms, 4, 5, 6, they are all relatively rare. They are rare forms of MODY. Now, what MCQ they will ask you? The MCQ they will ask you is, among them, which MODY is associated with exaggerated response to sulfonylureas? Which MODY is associated with exaggerated response to sulfonylureas? That is our MODY 3. The most common MODY is also associated with exaggerated response to sulfonylureas. This is associated with. Now, what do I mean by exaggerated response to sulfonylureas? I'll brief you that. So normally, where do we use sulfonylureas? We use it for treatment of type 2 diabetes mellitus. Type 2 diabetes mellitus. Now let us say that, okay, I did not recognize this as MODY, I considered it as type 2 and I started him on sulfonylureas. Now I know that type 2, they do respond to sulfonylureas, but I don't expect a great response. If I start, let us say 1 milligrams of glimepiride with a blood glucose level of 250 and I start 1 milligram of glimepiride, when the patient comes back for follow-up, I'm not expecting him to come with a fasting glucose value of 40 or 50. From 250, it may come to 220, 200, and I keep escalating the dose till I get the desired control. But if I start the same dose to a HNF1 alpha mutation, that is MODY type 3, I may end up with hypoglycemia. The dose which is unlikely to cause hypoglycemia in a regular type 2, here it may induce hypoglycemia. That's what I mean when I say exaggerated response to sulfonylureas. Okay. Another MCQ they will ask you is, among these MODY, there is one MODY which resembles the polycystic, autosomal dominant polycystic kidney disease. That is, these patients have slowly development of cysts in the kidneys. So they ask which of the MODY is associated with renal cyst. The MODY associated with renal cyst is MODY 5, HNF1 beta mutation. This is associated with renal cysts. Just like your autosomal dominant polycystic kidney disease, there will be development of renal cyst, and these patients also tend to develop renal failure over the time, right? So that is about our types of maturity onset diabetes in young. So this, how is it different from type 1? There are no antibodies. Okay. So there is no absolute insulin deficiency, there are no antibodies. And how is it different from type 2? There is no insulin resistance. Then both type 1 and type 2 are monogenic, they are polygenic, multifactorial, but here it is clearly single genetic mutation. Lifestyle factors do not play a role. It's purely a genetic disorder, right? So that completes our discussion of the types of diabetes mellitus, mainly type 1, type 2, how are they different, what is LADA and what is MODY. So now just to test our understanding, we will go through some questions. So here is one of the question, and I hope most of you should be able to answer this question. All these questions, diagnosis of types of diabetes, is all going to be based on your understanding of antibody profile in that particular patient, C-peptide levels. That's the crux plus presence or absence of insulin resistance. Okay. Now let's run through this question. A 27-year-old man presents with unintentional weight loss, polyuria and polydipsia for the past 3 months. So there are symptoms of, right? All these are weight loss, polyuria, polydipsia, polyphagia. They are symptoms of diabetes. He has no personal or family history of autoimmune diseases. BMI is 23. Labs show fasting glucose is 198 milligrams per deciliter. HbA1c is 9.1%. So before we go forward, you should now tell me, is he diabetic or not? Is he diabetic or not? Now we know the criteria, right? What is the diagnostic criteria for diabetes? Fasting plasma glucose value of more than or equal to 126 milligrams per deciliter. Here it is yes. HbA1c of more than or equal to 6.5%. Here it is yes. So that means this patient is diabetic. Now from the rest of the information, I have to diagnose whether it is type 2, type 1 or MODY or something else, right? So he is diabetic for sure. Diabetic diagnostic criteria is satisfied. Now what I get to know next, C-peptide level is low or undetectable. Low or undetectable. Then anti-GAD antibodies are negative. Anti-IA2 antibodies, insulinoma associated 2 antibodies are also negative. Fasting insulin level is undetectable. So C-peptide and insulin levels are undetectable. And patient is having urine ketones. He is prone for ketosis. He is having urine ketones. Okay. So now which type of diabetes it is? So here are your options. Type 1 diabetes mellitus, autoimmune subtype, type 2 diabetes mellitus, maturity onset diabetes of the young, or there is some rare variant called flatbush diabetes. I'll talk about it. And then idiopathic type of type 1 diabetes mellitus. So we'll run a quick poll and see how many of you can answer it right. So I'll give you 45 seconds. Let's run the poll and see how many of you give the right answer for this. We have seen the story. Right, here is a patient with symptoms of diabetes. Diabetes confirmed with the glucose values. C-peptide and insulin levels are undetectable. Antibodies are negative. And question did not talk about presence of any features of insulin resistance. Okay, so let's see the poll results. I have kept it for 45 seconds. Of course, you have already gone through the question. You should be able to answer it in few seconds. So what the low C-peptide or undetectable C-peptide level tells us in this question? Okay, so I think we had E options, right? So this poll makes no sense because this gave me only 4 options. Okay, nonetheless, absolutely undetectable C-peptide or insulin tells me what? There is absolute insulin deficiency. So when there is absolute insulin deficiency, what is the diagnosis? Absolute insulin deficiency, because C-peptide levels are, as you see in this question, the C-peptide levels are low or undetectable, and fasting insulin level is also low or undetectable. Can it be type 2? When C-peptide level is low or undetectable, can it be type 2? No, it can't be type 2, right? That is comfortably ruled out. In type 2, either C-peptide level will be normal or increased. Okay, it can't be type 2. Can it be type 1? Can it be MODY? Okay, again, when it comes to MODY, there is a point to note. What is the problem in MODY? There is failure to sense the rising insulin levels, but basal insulin production, beta cells will be constantly doing. So they don't have the absolute insulin deficiency. C-peptide levels will be detectable or normal, but there will not be rise in response to meal. As the blood glucose level increases, the beta cells fail to sense it, so they will not be able to secrete insulin. But the basal insulin production is normal. So MODY is not associated with low or undetectable C-peptide levels. So I can comfortably rule that out. Okay, so let us again, in fact, list all these features of MODY. So MODY, what are the features that MODY shares? First one, age at onset. Okay. We are saying maturity onset diabetes in young. So young means less than 30 years is the criteria. Okay. The second one, C peptide levels or insulin levels are going to be normal, not undetectable. Okay. Third one, more than or equal to 3 generations affected by the diabetes mellitus. Because being autosomal dominant, there is vertical transmission. There is vertical transmission. And then there is no autoantibody should be negative. Negative, and insulin resistance should be absent. Insulin resistance should be absent. So young individual presenting with diabetes with normal C-peptide levels, but no antibodies, no insulin resistance, and at least 3 or more than 3 generations affected by the diabetes mellitus, being a autosomal dominant mode of inheritance. So can this be MODY here? What are the factors going against the MODY? Question is not talking about 2 or 3 generations being affected with diabetes, first point. Second, the C-peptide levels and insulin level being low or undetectable. So that helps me rule out MODY also. So I have to decide between type 1 and type 2 diabetes mellitus. Type 1 is what? Type 1A autoimmune type, and type 1 idiopathic type, which is type 1B. So what should be our answer here? Yes, most of you got it right. It is type 1, and it is idiopathic type because antibodies are negative. So in the question, antibodies are negative. So correct answer would be idiopathic type 1 diabetes mellitus, type 1B. The same question, if I go back and flip and say one of these antibodies is positive, let us say anti-IA2 or anti-GAD is positive, then the diagnosis changes to type 1A or autoimmune subtype. Okay, I'll go through one more question before we wind up for today. Which of the following findings is unlikely to be seen in patients with MODY? So there are 4 options: hyperglycemia, young age of onset, acanthosis nigricans, and strong family history. Hopefully this poll we should be able to run. Okay. So let's run a quick poll on this question as well. Let's see how many of you can give the right answer. Which of the following finding is unlikely to be seen in patients with MODY? Hyperglycemia, young age of onset, acanthosis nigricans, strong family history. What is MODY? Monogenic form of diabetes because of single gene mutation. Age of presentation is young, less than 30 years of age. There is no type 2 or type 1 like mechanism. In type 1 absolute insulin deficiency, type 2 insulin resistance, they are not seen in MODY. Here either glucose sensing or insulin release mechanisms are being disturbed because of mutation in hepatocyte nuclear factor mutations, glucokinase mutation, or IPF mutation, or NeuroD1 mutation. Okay, so let's see the results. Okay, so I think 75% of you gave the right answer. Beautiful, fantastic. So hyperglycemia, to call it as diabetes, hyperglycemia has to be there. To call it as MODY, the age of onset has to be less than 30 years of age, right? And because it is autosomal dominant, for diagnosis, we need at least 2 or 3 generations of people having vertically involvement of diabetes. But acanthosis nigricans is a sign of insulin resistance, and there is no role of insulin resistance when it comes to the MODY, right? So that's why the answer here should be acanthosis nigricans, because this is suggestive of insulin resistance. And if I get any individual with hyperglycemia and acanthosis nigricans, what should be my diagnosis? Thus, it will be suggestive of type 2 diabetes mellitus, right? So I hope we have a fair idea about the different types of diabetes today. What I would suggest is now go back to the Q bank and solve the questions on the types of diabetes mellitus. Don't worry too much about the clinical features or the management. we will discuss that in the subsequent session. And once we complete the diabetes, we will run through a special quiz. We will cover all the important MCQs from the diabetes before we take the next endocrine disease, right? Okay, good. So that's it for today. So today we focused on understanding what is diabetes, what is the diagnostic criteria, and what are the types, and little bit of physiology we have touched. So in the next class, we will talk about the clinical